Occupational therapy reimbursement, evolution or revolution. This presentation is going to provide a historical look at the effects of reimbursement on occupational therapy practice from 1900 through today. In looking at the definition of revolution and evolution, revolution is defined by Webster as a sudden, extreme, or complete change in the way people live, work, etc. Evolution, as defined by Webster, is a process of change in a certain direction, the action or an instance of forming and giving something off, a process of continuous change from a lower, simpler, or worse to a higher, more complex, or better state, a process of gradual and relatively peaceful social, political, and economic advance. Historically, the reimbursement method for occupational therapy has driven its delivery system, as mentioned by photo. Prior to 1930, the moral treatment movement and Adolf Meyer set the stage for the foundation of occupational therapy. Focus was on adaptation in order to improve health following disease. Dutton said, "All patients should have occupations which they enjoy. Sick minds, sick bodies, and sick souls may be healed through occupation." After the Civil War, moral treatment movement deteriorated and the scientific, technological, pathological approach was formed. Occupational therapy maintained the focus on the adaptation to and engagement in the environment without much support from the medical community. With the lack of support and the need for funding changes needing to be made, the American Occupational Therapy Association in 1930 asked the American Medical Association to be the overseer of accrediting the schools. This placed the profession of occupational therapy in the medical model, thereby removing the autonomy of the field in the arts and crafts movement. Occupational therapy became financially bound with the American Medical Association. And the struggle between scientific, medical model, and moral treatment began. At that time, healthcare remained private and was basically industry-based. 1940 to 1960, the rehabilitation movement following World War II. Occupational therapy began to thrive, utilizing the functional approach and keeping veterans active following the war. New methods of treatment and frameworks were founded, such as neuromuscular facilitation, orthotics, vocational rehab, to name a few. Changes and ideas were happening quickly, and occupational therapy began utilizing approaches from other disciplines due primarily to staff shortage. Most therapists worked at military hospitals, in acute care hospitals, or schools. Funding during this period was private insurance or employer-driven. There was a push for federal funding of insurance. However, physicians and industry were able to push back and prevent the funding changes. Industry used insurance as a bargaining tool for maintaining their economic positions. OT remained in demand and grew in research at this time. In 1966, physicians lost their political power and Medicare and Medicaid was established. Occupational therapy continued to flourish, especially with the federal focus on community care for the elderly and underprivileged. Payment was on a fee-for-service basis, with treatment decisions being made by the therapist and physicians. And occupational therapy was active through the 60s and into the early 80s. However, many providers were taking advantage of the system and overcharging and underserving the patients. So the Tax Equity and Fiscal Responsibility Act of 1982 set limits on reimbursement, including occupational therapy. Areas of focus for occupational therapy were documentation and productivity. In 1983, the Social Security amendments were set in place, which were preparing us for PPS, or the prospective payment system. Acute care hospitals felt the push to shorten length of stay and ensure quality care in a shorter period of time. Therefore, the focus of occupational therapy shifted from the acute care setting to an outpatient setting, and a decline in staffing for occupational therapy in acute care resulted. In 1986, occupational therapy received Medicare Part B funding for nursing homes, home health, outpatient, and inpatient rehab. The Medicare amendments allowed occupational therapy to begin private practice and contract services as well. Occupational therapy was guided by the Medicare regulations as to what could and could not be considered skilled intervention, thereby changing the focus from chronically ill to acute disease management. Productivity became the expectation with initiation of computer documentation and staff management, including weekend therapy. Cost reporting became the barometer for staffing, and staffing was actually based on services reimbursed, not necessarily what was being performed. The occupational therapist gained ethical dilemmas to consider when thinking about billing, appropriateness of service provision, under or overutilizing, and staff shortage. Reimbursement drove decision-making for the clinician, physician, and facility at this time. So the OT implications during this period of time was documentation was crucial, inpatient census dropped, outpatient clinics increased, quality became a concern, and there were shorter hospital stays. 1990 to 2000. We saw healthcare reform, managed care, the Health Information Protection Act, and the beginning of assessment tools such as the MDS in the skilled nursing facilities. And that's the material data set. In 2009, the American Recovery and Reinvestment Act placed emphasis on biomedical and comparative research, health information technology, prevention, and wellness. Other areas for focus included obesity, smoking, chronic disease management. Scholarships and salary support for underserved areas were included. The area of disease management and obesity, as well as prevention and wellness, are not new to occupational therapy. And if you recall, historically, occupational therapy was founded on the chronically ill and well-being. This provides occupational therapy with experience and expertise to be integral to the focus of reform. In 2010, the Patient Protection and Affordable Care Act came quickly and placed increased emphasis on quality and effectiveness of care. Hospital readmission rates, hospital-acquired illness, and information technology became high priority. Evidence-based practice, client-centered, high-quality, and multidisciplinary care are expected. Validated assessments were to be utilized. Clinical areas for management and quality initiatives, including fall prevention, chronic obstructive pulmonary disease, total hip replacements, health literacy, and independence at home. These all sound very familiar to occupational therapy, as this is part of the framework. The Impact Act of 2014, which stands for Improving Medicare Post-Acute Transformation, is part of the Affordable Care Act and was established to ensure the quality of care across the continuum of the post-acute healthcare provision. Focus would be placed on collecting and reporting quality measures, functional status, and other pertinent areas for data collection. Post-Acute Care Value-Based Purchasing Act in 2015 was established for quality management focusing on Medicare spending per beneficiary, or MSPB. The purpose is to advance practice and focus on the outcomes most valued by patients, their family, payers, and society. And this act included episode-based management, the bundled payments, and the population, similar to what was initially started with prospective payment system. In reviewing the literature from the founding of occupational therapy, it is easy to conclude that reimbursement in occupational therapy is an evolution of the revolution. But to quote Howard in 1991, we as occupational therapists must be aware that social factors influence the direction of the profession. Reimbursement issues not only frustrate clinical practice, but participate in shaping occupational therapy. We must be aware of the causes of constraints on practice in order to be proactive in issues of healthcare policy. And that brings me to today. In 2017, we will have met our centennial vision. The centennial vision, according to AOTA, is to be a powerful, widely recognized, science-driven, and evidence-based profession meeting society's occupational needs. This is not going to be the end of the changes. It's only the beginning. And as we go forward, as occupational therapy always has, we will continue to evolve by the revolution. Thank you.